Hi, everybody. My name is Chris Buse, and I'm an education specialist at CAMH Education. And I'm happy to introduce our breakout session here. It's called it's called Bridging the Gap Between Hospital and Community. Our speakers are as follows: Narges Beyraghi, who's an addiction psychiatrist at CAMH and an assistant professor at the University of Toronto. She has worked in developing pathways and partnerships with community treatment centers to improve efficiency in addiction treatment service. We also have Janet Hill, who's a nurse practitioner and has been involved in the addiction services at CAMH for the past 10 years. Currently seconded since the pandemic to the medical withdrawal service and intensive recovery discharge team, where she works closely with the interdisciplinary team to facilitate the transition from hospital to community. And we also have Sofiya Hudani, who is a clinical pharmacist at the Center for Addiction Mental Health, CAMH. Sofiya graduated from U of T with a Doctor of Pharmacy degree. She has acquired experience in a variety of clinical practice settings, including acute care, ambulatory care, and rehabilitation and complex continuing care. So I'll let you get started. I think, Narges, you are our first speaker.
Yes, I am. Thank you so much for your kind introduction. And I want also to thank you for all of our participants to have interest to our sessions. I'm honored to have two of my colleagues today who are presenting with me, and they both have a lot of experience in addiction and transitions of care. I want to start what was the reason that we are talking about bridging the gap between hospital and community. The reason that we decided to pick this discussion is that it's very important and it's a hot topic, gaining a lot of attention these years. The reason is that transition of care is a very vague concept, but at the same time, you can see that transition happens in almost any clinical encounter, even though in specific settings like transition between hospital and community, we have a lot of transitions happening. And a better transition of care could improve the efficacy of treatment and healthcare and also patients' outcome. The other reason that we are talking about it is that we have experience in this area, and we know that we are not planning to transfer knowledge. We want to make this presentation very interactive. So please help us with sharing your experience in the chat with us and also answering our polling questions. Thank you. So we do not have any disclosure, none of our presenters. Let's talk about learning objectives. The way that we are going to present the transition of care today is case-based. So we are going to go through one specific case, and through that we are going to cover our learning objectives. Our first learning objective is to gain familiarity with services who support the transition from hospital to community, including the service that we have, and we are working on it. We are going to describe the importance of care transition in addiction treatment and opioid use disorder, and we want to identify opportunity to safely and effectively intervene during transitions to improve treatment outcome for patients. We want also to highlight the importance of interprofessional collaboration. As you know, when our patients start to have complex biopsychosocial problems, the importance of patient-centered care and interprofessional collaboration is higher. So we are going to emphasize on that, and we are going to discuss the challenges of care transition and the value of connecting patients to addiction support. This is who we are. This is the IRDT team that you can see. We are a group of clinicians, compassionate, dedicated clinicians with different area of expertise. We have social workers, we have pharmacists, we have administrative, we are psychiatrists, and we have also nurse practitioner in our group. The reason that this group developed, and this is an innovative program at CAMH, was that after the pandemic started, one of our unit who was responsible for stabilization of patients actually was closed. Staff were redeployed. At the same time, we had a lot of other resources in the community for addiction that went down. So we developed this interdisciplinary team to help our addiction patient with concurrent disorder for transitions of care. The way that our group function is that we meet with patients while they are in hospital for a consultation and also to develop rapport and understand what's their goal when they are in hospital. If you attended the first sessions of this conference, you heard that hospital could be a very difficult, scary situation for opioid use disorder patient and other addiction patients. So we try to understand where our patients are, and then we remain connected to them for 2 weeks after discharge to help them to land safely in the community and to be able to connect with their care provider in the community. We are providing psychiatric follow-up, relapse prevention sessions, care coordination, and we are very flexible in phone, video, in-person appointment, family sessions, and case conferences with care providers in the community. We have been able to serve more than 700 referrals during these 2 years. I want to talk just as a brainstorming. This JAMA article compares rate of overdose and hospitalization when opioid OAT starts inpatient versus when OAT starts as an outpatient. We have a lot of evidence that shows that the best place to receive care for opioid use disorder patient is in the community, not in hospital. But at the same time, we know that opioid use disorder patient for different reasons may end up coming to emergency department and hospital due to medical complications, psychiatric complications, and also significant psychosocial problems. This study's result shows as we expected. So shows that a short-term inpatient stay is the worst for risk of overdose after discharge and also rehospitalization. If we don't start opioid agonist therapy, even if the short term starts the opioid agonist therapy, still the rate is high. So the best way to start opioid agonist therapy is in the community. But the problem is that our patient needs other care and they end up in hospital. And we can argue and see what's the reason. We want to know what's the reason that this is happening, that the patients after discharge are not able to connect it to their care provider in the community. The finding of this study shows that initiating opioid agonist therapy alone was associated with better outcomes compared with inpatient treatment, even when inpatient treatment were followed with opioid agonist therapy. This suggests that a multi-step approach to initiating opioid agonist treatment may present barriers that are associated with decreased efficacy of this treatment. In previous studies, transition periods following inpatient care has shown to be associated with elevated risk of overdose, and this association may be present in any transition from inpatient care to outpatient. This is the result of our work. So this is the initial evaluation that we just published for our first 200 patients. We also collected patients' feedback, and we received a very good feedback from our patients. And we have some unpublished data of our 700 patients. the reason that I present this slide showing that because we are accepting patients from inpatient units, not all of them are opioid use disorder. 30% of our patients had opioid use disorder, and say close to 70% other substances, mainly alcohol. The group of patients that we are serving are usually patients with different comorbidities. So as you can see, 20% of our patients are homeless, 66% of our patients have polysubstance use disorder, 60% they have significant medical comorbidity, and 70% of our patients also had psychiatric comorbidities. We had done a first analysis of our 700 patients, and the interesting result that we reached is that our opioid use disorder patients, compared to other substance use disorder patients, are doing better. So when we are, for example, looking at our outcome being coming back to emergency department or rate of rehospitalization, our opioid use disorder patient in these 700 patients are doing better than other substances. The reason could be different because we have medication for opioid use disorder. Could be that transition of care is happening better for opioid use disorder, but this is area that we are going to work on it. I am passing the presentation to Janet.
Hi, everyone. I'm Janet Hill. I'm the nurse practitioner on the team. So this case is based on, it's a fiction. It's based on a number of different issues that clients who present to the medical withdrawal service bring with them. So our case involves a 33-year-old female living in Toronto community housing where substance use is prevalent, financially supported by ODSP. Her substance use history involves fentanyl use, intravenous fentanyl use, 4 points or 0.4 grams daily, along with some cocaine use by either insufflation or smoking. She has a history of problematic substance use since around age 17. She did have a period of abstinence from age 25 to 30. During this time, she was able to develop some stability in her life, was able to bond in a committed relationship and give birth to a daughter. In terms of her psychosocial history, so the reason for her destabilization and relapsed substance use, she attributed to a history of sexual and emotional trauma that occurred about 3 years ago when she was sexually assaulted by a coworker. As a result of the injection drug use, she developed a Hep C infection, and that's also part of my discussion. This is a discharge plan that we put together. It would be very typical of the kind of discharge plan that we would, that clients would have on leaving the hospital. So in this instance, she was connected to a rapid access addiction medicine clinic for continuation of her opiate agonist therapy, referred to a residential or addiction treatment program, referred to our bridging service here at CAMH. This is a non-acute walk-in service for people with concurrent disorders. She was referred to a harm reduction facility a community harm reduction facility that she was familiar with for Hep C treatment. So our case scenario follows that unfortunately the things did not go well when she left the hospital. that we presuppose that due to stresses of returning to the community and reestablishing ties with her high-risk acquaintances, particularly at the community harm reduction facility where she'd been referred for Hep C treatment, unfortunately she relapsed and overdosed. So, as is often the case when these scenarios occur, we find ourselves thinking about what we could have done differently. This is our first polling question. So some of the options that you might consider are things like she could have been discharged to a pre-treatment bed or a more stable housing situation, such as with a family member. Perhaps we could have extended her stay in hospital to further stabilize her opiate agonist therapy. We could have connected her with a case manager and peer support group to kind of prevent her from getting reconnected from some of her high-risk acquaintances. Also, perhaps scheduled specific follow-up times in order to create a structure and routine for her to follow in the early days of her leaving hospital. So I welcome your feedback. You're welcome to begin voting. I see that many of you have already started. This is great. Okay, I think that let's have a look at the results. Just know that some people are still voting. Okay, I think we're good. I think everyone stopped voting. So let's share the results of the poll. Okay. And just to say that sorry, I've lost my slides here. Thank you. Just to say that any or all of the answers would have been correct or other options for us to have pursued in this instance. So I'm just going to shift gears a little bit and talk about some of the elements of transition that we've tried to identify and focus on in our practice. And this is a very busy slide. I'll just encourage you to mostly follow along on the left-hand side. So the first element being medication management. This is a core piece of our business in terms of discharging people from hospital. And I'm not going to speak much more about that because Sofiya will address those issues in her discussion following mine. In terms of transition planning, so we attempted this in terms of setting her up with a referral to a RAM clinic, trying to connect her with the bridging service, an application for addiction treatment, and also a referral for Hep C treatment. So those are some of the kind of concrete approaches we took to that portion of the transition. Another significant component of transition planning is patient and family engagement. So a lot of our clients are not familiar with all of the options and resources that are available to them. So part of our work is providing them with information about the full scope of options that are available to them, and helping them to make decisions about what would work best for them and best enhance their recovery. In terms of communicating and transferring information, this is everything from the usual protocol of faxing the discharge summary to the family doctor, but in many instances our clients don't have family doctors and they're relying on other kinds of care providers to help them fulfill their goals. And so we would communicate with those people. That could be a caseworker, a family member, for instance. In terms of follow-up, this can be as concrete as actually booking people appointments. This is something that we found to be very helpful for clients, rather than giving them information and recommending that they call on their own. A lot of clients are overwhelmed when they're leaving hospital, and so knowing that they have an appointment on a specific day and time has been actually reassuring for people. And then the other component is just in terms of the engagement level of the healthcare provider. It's been demonstrated that having ownership, responsibility, and accountability for the care of the patient and family helps to increase the support or the trust of the client and helps them to feel more supported. This is another model of care transition. I'm going to focus my discussion on the transition practices component. So as you can see, there's sort of a continuum here of less intensive to more intensive in terms of different approaches. The least intensive approach would be to provide the person with information, phone numbers, resources on discharge, and recommend that they follow up at their earliest convenience. The next level, slightly more intensive, would be on a line basically with what we do in the intensive recovery discharge team. So providing telephone support, calling people for check-ins, calling people for reminders. And then of course, the more intensive approach is connecting somebody with intensive case management, where there's a case manager who's fulfilling the role of calling the person, even going so far as to accompany them to appointments. And that isn't to say that like all of these different approaches have some value. It depends entirely upon where the client is at and what level of approach would work best for them. This is another model of collaborative care planning. This places the client or the patient in the center of the circle of care that involves hospital, community programs, and home-based services. So switching gears again, just going to talk a little bit about referring people to Hep C treatment. This has become a greater focus of my practice over the past few years. And because the evidence suggests that people who use injection drugs make up half of those who ever had a Hep C infection. And based on recent statistics rather, they make up between 60 and 85% of all new infections. These are some of the other risk factors for developing Hep C infection. I won't review those in detail. In terms of actually referring people for treatment, I found this website, the Ontario Hepatitis C Teams Network. Basically, it's like a yellow pages or a listing of all of the various team-based services across the province of Ontario that provide support for clients who are seeking treatment for Hep C. And that could be everything from community health center or harm reduction programs to hospital-based services. I'm just going to skip over that. Sorry. And in terms of, just wanted to highlight a couple of areas that may be of interest to people, in particular the Echo Liver Project. This is a seminar series that, a workshop seminar series that's run by the liver team at the University Health Network. I've attended it. I highly recommend it if you're at all interested in learning about how to treat hepatitis B or C or other liver diseases. This is a very valuable program to attend. And in addition to that, so there are some specialized clinics that people can attend for liver and Hep C treatment, as well as as I mentioned, the hospital-based services. A lot of the clients I've met find that they're not so inclined to go to the hospital-based services just because they tend to be a bit more intimidating about going into the hospital kind of institutional. They align hospitals with institutional care. Okay, I'm going to pass it on now to my colleague Sofiya. So Sofiya, thank you.
Thank you, Janet. Hi, everyone. My name is Sofiya, and I'm one of the pharmacists on the team. So keeping the collaborative care model in mind leads our discussion into how can we best support our patients and the transition of their care from hospital to community. This involves closely collaborating with the patient as they are at the center of our care and making sure that they are well connected to the interprofessional allied health team, community-based care providers, and other outpatient support services. It's important to stress here that everything that we do is with and for the patient. So taking into account their preferences, values, and wishes is integral when planning the transition of their care. Medication management, as we know and have discussed, is a critical component of care transitions. Part of the process of safely transitioning patients, specifically with opioid use disorder, involves providing adequate and effective education on their opioid agonist treatment. This helps to reduce the risk for medication errors, facilitate better treatment adherence, and overall improve patient outcomes. So for example, a patient on buprenorphine naloxone should be educated on effective sublingual administration for the medication to work, as chewing or swallowing can reduce the medication's effect, as well as they should be educated on refraining from eating or drinking for at least 5 minutes afterwards to allow the medication to be absorbed. Harm reduction should also be part of that discussion with the patient, knowing that not all patients may choose to completely abstain from substances. So patients should be provided with a naloxone kit and opioid overdose prevention training. Sometimes the information that we convey to patients can be quite overwhelming. It can be hard to absorb and retain. So supplementing with patient education handouts is always a great idea. Medify is a great resource for patient education material on OAT. And lastly, together with the patient, it's important to come up with a plan for monitoring their OAT and for ongoing follow-up. One thing I do want to mention that's not included in this slide is medication coverage. Not all patients will have coverage for their OAT, either through ODB or private insurance. So in such cases, it's important to work with social work to help patients in applying for social assistance, since oftentimes medication cost can be a barrier to maintaining treatment adherence. We often encounter situations where the application will not be approved right away. And so what do we do in such cases? One option is requesting for compassionate supply from the manufacturing company. So let's say if this was in the situation of buprenorphine naloxone, there is a financial assistance request form available from the company that the prescriber can fill out and submit to the company for the patient to receive a 3-month compassionate supply per request. So facilitating seamless care for patients with opioid use disorder also requires maintaining clear and open communication with their pharmacy throughout their OAT treatment. This is important because the community pharmacy will likely have the most interaction with the patient, particularly at the start of treatment when patients are on daily observed dosing. So the pharmacy really does become your ears and your eyes to how well the patient is progressing. To ensure safe and appropriate dispensing of OAT medication, it's important to ensure that the prescription has all the necessary details and requirements, including the current dose, indicating whether this is a new start, a dose increase, or dose decrease. This is particularly important if there's already a valid prescription on file that must be canceled. The date and time of the last observed dose, and if the patient may have any carries in their possession, planned start and end dates for doses, as well as specifying the days of the week for observed dosing versus take-home dosing. So now let's visit a poll question. This is coming back to our patient, Sarah. Sarah is requesting that her prescription for daily observed dosing be sent to her regular community pharmacy for dispensing. However, her pharmacy is only open Monday to Friday. What would we recommend in this situation? Should we help Sarah find another pharmacy that's open 7 days a week and have her fill the entire prescription there? Should we arrange for guest dosing on the weekends at another pharmacy? Should we inform the prescriber that instead Sarah will require a take-home dose for Saturday and Sunday? Or do we not do anything? So we're gonna set up a poll for voting, and we'll give everyone about half a minute to vote. Perhaps we'll end the voting there and review the results. Okay, so thank you to everyone who participated. I see some interesting answers here. The majority selected inform the prescriber that Sarah will require a take-home dose. The second best answer here that was chosen was arrange for guest dosing. And then option number 1 was the least selected answer. That's very interesting. So in such situations, what we've done in the past, it's ideal to actually have Sarah fill the entire prescription at one pharmacy. And this is because that helps to ensure continuity of care when the prescription is only at one pharmacy. It also helps to reduce the risk for any medication errors. Guest dosing is not ideal because it does increase communication needs between pharmacies. However, it can be preferred over take-home dosing, particularly for patients who do not meet stability criteria yet for having carries. However, this answer will differ based on a case-by-case basis based on your patient's circumstances. So it really can be approached in different ways. So we'll continue on with the presentation. So now since we've already established that the community pharmacy is an important point of contact for the patient, because they are, as we said, they are our eyes and ears to how well the patient is progressing. So we really want to make sure that they are well equipped to support and optimize the patient's OAT care in the community. And for that reason, it may be useful to share with the community pharmacy any relevant clinical issues that may require ongoing monitoring, such as the patient's level of adherence to their OAT dosing schedule, any drug interactions with other prescribed medications, for example, the risk for CNS depression with other CNS depressants, expectations for the OAT treatment process, including monitoring for intoxication, withdrawal, other medical psychiatric comorbidities, as well as missed dose situations. If any of these cases arise, or if any of these situations arise, it's important to outline a plan ahead of time of how best to communicate with the prescriber to address any concerns that may require reassessment of a patient's OAT treatment. I just want to highlight here that members within a patient's care team generally have that implied consent to communicate with each other because they are within that circle of care. However, it's still a good idea to check with the patient and get their expressed verbal consent for communicating with other care providers. If patients have any concerns with this, then it's good to explain to them the reason and how this is in their best interest and for safety purposes. Also encouraging them to take that accountability and share this information for themselves with their prescriber. So we're going to have our third poll question here. Under what circumstances should the pharmacist consult the physician regarding reassessment of Sarah's OAT dose? Is it if she presents with adverse effects secondary to a possible drug interaction with her OAT? If she's showing signs of intoxication to recent alcohol use? If she swallowed her buprenorphine naloxone doses? If she has missed any doses? Or all of the above? So we'll start the polling now. Perhaps we'll end the voting here. Okay, so the majority of you answered all of the above, which is correct. All of these answers or all of these case scenarios warrant a physician consultation to reassess a patient's OAT therapy, as this can influence decisions regarding dose changes, as well as a patient's take-home status. So we'll go back to our slides here. All right. Okay, so we're going to come back to the topic of patient education. As we discussed already, not only is it important for the community pharmacy to be aware of the patient's OAT treatment expectations, it is just as imperative for patients to be aware of these expectations. We know that there's a high likelihood for a relapse for patients using opioids, and the dangers of this, of relapsing to potent opioids like street fentanyl. This makes it especially important to educate patients on loss of tolerance following missed doses, or even in the case of a prescription overlap where patients are using multiple pharmacies on an ongoing basis. That being said, to avoid such circumstances, it may be beneficial for the pharmacy to have the patient sign an opioid treatment agreement, which clearly sets out the expectations for the patient in adhering to their OAT. And this can be reviewed every so often. Also, it may be worth noting here that as part of the pharmacy's treatment agreement, What should also be included is the part on communicating with other members of the care team in order to best support the patient's care. So now we'll switch gears and move on to harm reduction. Harm reduction is another integral element of care transitions and overdose prevention. It acknowledges where patients are in relation to their treatment for opioid use disorder. And it also accepts the fact or respects the fact that not all patients will be ready to stop yet. So for this reason, harm reduction really responds to patients in a flexible way. It allows patients to feel more comfortable, which increases the likelihood of a successful outcome. As stated here, without harm reduction strategies, engagement with healthcare providers would more than likely not occur at all for many people. That's why it's so important that harm reduction be integrated as part of the continuum of care for all patients with opioid use disorder, regardless of their treatment modality. Harm reduction seeks to increase patient safety by taking a non-judgmental and client-oriented approach to reduce some of the risks associated with substance use in patients who may continue to use substances. So in essence, incorporating a harm reduction approach aims to promote patient safety by essentially being more approachable. That is, checking in regularly with patients about concerns that they may have or inviting any questions, scheduling patients for regular follow-ups for ongoing monitoring and reassessment, offering patients supportive counseling, education, and information at an appropriate literacy level, and discussing concepts such as safer injecting, opioid overdose prevention and intervention, as well as risks associated with loss of tolerance and mixing opioids with other substances. Connecting patients with local health resources, connecting patients with their primary care provider for infectious disease testing and providing immunizations. And very importantly, addressing social determinants of health, as patients with opioid use disorder may be using opioids to cope with other problems in their life. So it's important that we refer patients so that they can get the support they need to obtain housing and access food programs. A harm reduction approach should also involve counseling patients on the steps that they can take to remain safer and to reduce the effects of high-risk behaviors, as well as avoid an overdose situation. This includes carrying a naloxone kit and knowing how to use it. Avoid using opioids alone, not mixing opioids with other substances or sedatives such as benzodiazepines or alcohol. Ensuring that they know what substance they're using. And if it's a new supply, using small test doses. For patients who continue to inject, educating them on safer injection techniques, such as accessing sterile supplies, such as clean needles, avoiding reusing or sharing supplies, and practicing hand hygiene prior to administration of the substance. So these next two slides focus on resources related to harm reduction. And for the interest of time, I'm not going to go into great detail in discussing these slides, but just want to bring to your attention that these resources, some of which you may already know about, they are available for your patients to access. And so if you are interested in learning more, the links here are provided. So for more information on sterile drug consumption equipment, visit the Ontario Harm Reduction Distribution Program. For more information on supervised consumption sites, which are also known as supervised injection sites, these sites provide a hygienic space for patients to use pre-obtained substances under the supervision of trained staff. And these staff provide education on safer use. So to learn more about this topic, there's more information available on the Health Canada website. And for information on safer opioid supply to help reduce illicit use, also visit the Health Canada webpage. And referenced here is a guiding document for primary care teams. On that same note, these are additional opioid overdose prevention resources, and I just want to give special thanks and credit to the CAMH Pharmacy Department, Tiana Costa, as well as Andrea Sanos for sharing these resources with us. These are great resources to share with your patients to access on how to prevent an overdose. There is a National Opioid Overdose Response Service, also known as NORS. This is a overdose prevention hotline available only within Canada, and it provides confidential support to patients who use substances. There is an app version of NORS known as the Brave app, and this app can be accessed outside of Canada. And then there is the Toronto's drug checking service. This is coordinated by the Centre on Drug Policy and Evaluation, and it analyzes a patient's substance, a sample of their substance, and provides comprehensive and timely information on the composition of their drugs. And it's completely free and anonymous. There's also additional harm reduction resources available by visiting the Portico website. And one thing I do want to emphasize here is that in order to best support your patients with opioid use disorder, it's always good to understand the various ways that patients use their opioids and avoiding any stigma, guilt, shame as a barrier to providing and seeking that care. So we have our final poll question. Which of the following patients should be offered harm reduction counseling and access to resources? So again, we'll give you half a minute to answer. So just being mindful of time, I think we may want to just stop the poll there. Thank you everyone who has participated. So the majority of the audience has chosen all of the above, which is absolutely correct. Harm reduction should be offered to all patients with opioid use disorder, regardless of their treatment modality, including those who are actively using opioids to some level, those who may have completely stopped using opioids, those who are receiving OAT, or those who are in recovery. So thank you everyone for participating. And we have a few more slides left, which we will end off with. Okay, so now we'll move on to the follow-up plan. What should be included as part of that follow-up plan? So it's important for patients to be connected to addiction support, and that is the Rapid Access to Addiction Medicine Clinic can support patients who have any substance use disorder. RAM is a walk-in clinic for patients to attend to get help for substance use. And this clinic provides counseling services, pharmacotherapy, and can also connect patients to other community services. For more information on nearby RAM clinics, visit the Medify webpage. Sorry about that. Okay. And now just coming back to our patient case, Sarah. Sorry, there is some mix up with the slides. Okay, coming back to our patient case, Sarah. So let's say given Sarah's poor adherence to Suboxone, we decided to transition her to long-acting buprenorphine once monthly subcutaneous injection to reduce her risk of relapse. So when planning the continuation of long-acting buprenorphine injection or Sublocade in the community, it's important to note that Sublocade does need to be administered by a trained healthcare provider, and that not all RAM clinics will give the long-acting buprenorphine formulation. So it's best to call a RAM clinic in advance to inquire. For ease of reference, however, Medify has created a list of OAT clinics that can prescribe and administer the long-acting buprenorphine injection. And attached here or referenced here is a link for your reference. Okay, so this brings us to the end of our presentation. In summary, the key elements of care transitions include medication management and psychosocial interventions. We want to conclude by saying optimizing transitions of care has shown to improve patient outcomes, and it truly involves the support and engagement of all members of the care team to make that difference in the patient's care. Thank you all so much for attending, and we're happy to take any questions.
So thank you, Sofiya and Janet. We have a lot of interesting questions that I'm going to go through them quickly. So the first question was about what's usually happens in emergency department, that patients are discharged quickly. Yes, we agree with you. And sometimes we are also accepting patients from emergency department that this has happened to us, that they are calling us and we have to go there in 5 minutes. And we have learned to ask one question from the patient: what's your phone number? Confirm that. Do you want to continue your care with us or not? And then our sentence is, whatever happens, answer your phone. We are not an abstinence-based program. So this is going to show them that they can continue their care with us. We confirm the phone number and then the patient is discharged. So basically we are aware of this situation, and even most of the emergency department doesn't start the OAT, which is against the guidelines. So some of the questions has been answered separately. Housing is a major issue. We agree. We have a lot of patients that the main concern is housing, and when they don't have stable housing, their care is going to be affected. Even they don't have a phone. So we have patients that they are providing the shelter's number for us to contact them, and we are doing that. Some of them, they are coming to CAMH because they don't have a phone, and we provide just the time and how to come back and see us. There was a lot of the suggestions about some of our polling questions. I would say all of them were very good and interesting. That safer supply also could be helpful on the polling questions. I'm going to pass to one of the questions that was related to Sofiya regarding question about Suboxone, that probably we don't need to have Suboxone being witnessed. And I don't know if, Sofiya, do you want to answer this question or?
So yes, that would depend on the patient's clinical stability. Do they meet criteria yet for take-home doses? I do agree with you on the point that Suboxone is generally safer than methadone or slow-release oral morphine. So take-home dosing can be started much sooner, and we can be more flexible with take-home dosing in comparison to methadone. But at the same time, when starting treatment, you really do want to make sure that the patient meets the criteria for take-home doses and has had that period where we've observed clinical stability on observed dosing before we make that decision to transition them to take-home doses. And that's going to vary patient by patient when they achieve that clinical stability.
And thank you, Sofiya. We have another question about the compassionate supply. And
that's a great question. So the manufacturer for Suboxone is Indivior. And if you connect with that company, they do have have a financial assistance program where they can help with compassionate supply for 3 months. And it just requires that the prescriber fill out and submit that form to the company. And usually the supply is received within a couple of days.
Okay, so we have another question from Heather saying that OATC required to notify family physicians and community pharmacy that the patient is receiving OAT from their clinic. I have been told that the patient is required to share that information, which doesn't consistently happen. I don't know who wants to answer this question. This is a safety concern and happens a lot. It's that a patient is on opioid agonist therapy and the family physician is not involved. For example, is receiving from a RAM clinic, or for example, the patient is on Sublocade and the community pharmacy is not aware. For example, is receiving the Sublocade at CAMH and the community pharmacy is not aware that the community pharmacy who's providing other medication is not aware that patient is on Sublocade. So this is a very good example of care coordination that needs to happen. When you are prescribing a medication, you need to make all of the care provider aware of it. The issue sometimes happens when the patient doesn't want to share information with part of their care provider. For example, they are not providing consent for their discharge summary to be shared with the family doctor. But most of the evidence in literature shows that the best outcome happens with all of the care provider are all involved and trying to do the best of their knowledge and the best of their potentials for patients to reach their goals. But when this is not happening for different reasons, this could be patient's barrier, this could be provider's barrier, we are all aware of it, but this definitely is a safety concern. Information needs to be shared. We have another question. This is a suggestion that probably your polling question was better to be set with another medication, not Suboxone. There is another comment, important to maintain relationship with community pharmacy, that she already had a good rapport. Yes, we have a lot of patients that their outcome has changed because they have a very good relationship with their community pharmacist. Yeah. And the community pharmacist is the person who is leaving me messages when the patient is in need. So
we're at 12:35 now.
Okay, so when we stop.
So there were a couple of comments, and I know we don't really have time to get to them, but I don't know how to. There were a couple of questions or comments about the usefulness or whether it's necessary to have the treatment agreement with the pharmacy, and also the role of the pharmacy in ensuring proper consumption of the medication. I'm not sure how quickly that could even be talked about, but we're at 12:35. Yeah. So
I'm going to just say one sentence. The spirit of this agreement is not to sign something, is actually to understand exactly what's going to happen. It's the passing the information. Signing that I don't think that has a value. As a clinician, I want them to exactly know what's going to happen and not be surprised. For example, if they miss 3 doses of methadone and their prescription is stopped during the titration phase, they need to know about it in advance that this may happen. Another comment, they are asking for resources. All of our presenters has signed an agreement to share the slides, so our slides is going to be shared later with the video of this presentation.
Thank you very much for all of your presentations, and thank you to all the participants for your questions and your comments. Have a great rest of the day.
Thank you all.
And thank you.
Thank you for attending and for your time and attention.